In the previous classes, we had spoken about assessment, then preparation of the patient. Today, we are going to speak on pre-operative preparation, how the patient is optimized for the operation. Number one very important dictum is, if you fail to prepare for the patient, you are prepared to fail when you are in the OT. So preparing the patient is of utmost importance. By definition, the preoperative period runs from the time the patient is admitted to the hospital to the time the surgery begins. This is quite a big time. What are the preoperative plans? Gathering and recording concisely all relevant information, planning to minimize risk and maximize benefit for the patient. Very important. The risks must be minimized, the benefits must be maximized. You should be prepared for adverse events and should know how to deal with it. Communicate freely with the patient and with the patient family if you feel that there may be any problem during operation or post-operatively. Just to recapitulate, the patient assessment which we had already done comprises of history taking, examination, investigation, preoperative treatment, documentation and communicating with the patient. Just to recapitulate, principles of history taking: listen to the patient, what is the problem? Clarify, what does the patient expect from you? Narrow it down to the differential diagnosis you have, and check on the fitness of the patients. What are the comorbidities like hypertension, diabetes, hyperthyroid, hypothyroid, any other disorders. Past medical history: cardiovascular, can have ischemic heart disease, hypertension, heart failure, dysrhythmias, peripheral vascular diseases, deep vein thrombosis and anemia. In the respiratory system, we can have chronic obstructive pulmonary disease, asthma, fibrotic lung conditions, lower respiratory tract infection and malignancy can be there. In the gastrointestinal system, you can have peptic ulcers, GERD. You know what is GERD? GERD is gastroesophageal reflex disorder. When there is, from the stomach, food comes out into the esophagus. The bowel habits of the patient, malignancy of the GI tract, and of course liver diseases. In the genitourinary system, you can have urinary tract infection or kidney dysfunction. In neurological system, there can be, patient can have a history of epilepsy, may be on drugs or may not be on drugs. CVA, that is cerebrovascular accident, patient can be psychotic, or patient can have a cognitive dysfunction. In endocrine system, patient can have diabetes, thyroid dysfunction, pheochromocytoma. Patient may present with very high blood pressure which cannot be controlled, and on investigation we find that the patient has a pheochromocytoma. So the primary cause instead of the operation, will be focused on the pheochromocytoma. Musculoskeletal system, patient can have osteoarthritis or any inflammatory arthropathies like rheumatoid arthritis. Infections like tuberculosis, hepatitis, or human immunovirus, HIV. Coming to the examination, the general examination should also include findings if not related to the proposed procedure. Very important. Findings which are not related to the proposed procedure must be explored. Then the surgery related problems, why the surgery is taking place. Systemic examination of comorbidities and their severity. And very specific examination, for example, the patient in a kidney stone patient, to remove the kidney, the patient has to be in a jackknife position. What is a jackknife? Jackknife is a knife which can it is closed like this, and you press one button and it opens like this. So it doesn't open straight, there is a little bit of curve. So jackknife position is the position of the body which is a bit curved, angular. Coming to the physical examination, it can be general, systemic, of the cardiovascular system, of the central nervous system, of the GI system, and the respiratory system. Specific medical examination. The aim is to evaluate the presence and severity of other problems. Diabetic patients undergoing surgery need careful examination for sepsis, diabetic neuropathy, or diabetic microvascular diseases, which are very common in long-standing diabetics. Renal disease patients need fluid restriction, very important, because patients have a fixed urine output, so the input must be fixed in a lower rate, otherwise the patient's body will accumulate the fluid. And usually renal patients have anemia, so there has to be a blood transfusion. Of the baseline investigations, we'll have to have a full blood count, FBC. The basic biochemistries, you all know by now what is basic biochemistry, and the chest X-ray. Targeted investigation, hematological, to exclude anemia, platelet count, prothrombin time, international normalizing ratio INR, to assess the coagulation profile so that during operation and post-operatively the patient does not bleed excessively. Urea, creatinine, and electrolytes, of course, to see the hydration status of the patient and the renal status. Liver function tests, albumin, protein, bilirubin, these will show if the liver is functioning well, and also SGOT and SGPT, the primary enzymes of the liver. Thyroid function test to exclude hyper or hypothyroidism. Other investigations are ECG, recommended in all patients above the age of 40, with blood loss. These become very prominent, so the ECG is very important. Echocardiography should be done in patients above the age of 50, or if the patient has cardiac anomaly, can be done much before that. Urine analysis to determine the renal function, inflammation, infection, and if there is a metabolic disorder in the patient, like acidosis or alkalosis. HbS, Ag, and HIV tests are a must these days because they screen that the patient is without these diseases, so that the doctor, the nurse, and the post-operative caregiver are safe. RBS, that is random blood sugar, and HB1AC, that is glycosylated hemoglobin, are done to check on the diabetic condition. If the patient gives a history of a missed period in the reproductive age group, a pregnancy test should be done. What are the preoperative problems? Number one is hypertension. It's a number one problem. Preoperative blood pressure should not exceed 140 by 90 millimeter mercury. Newly diagnosed HTN must be put on drugs to reduce the blood pressure. Acute admission for acute emergency or urgent surgery, they need to have their blood pressure brought down immediately by the anesthetist. Ischemic heart disease like dysrhythmia. Patient can have atrial flutter, fibrillation. Patient may be on warfarin, which should be stopped 3 or 4 days prior to surgery. And patient can have ectopics also, supraventricular, ventricular ectopics, which should be treated, because during surgery these can become a major problem and may cause morbidity and maybe mortality. Heart block. In the second and third degree heart block, you must think of a temporary or a permanent pacemaker before you take the patient up for surgery. First degree heart block can be done without any pacemaker. If there is a myocardial damage, that is a myocardial infarction recently, within 3 months one should avoid surgery unless it is very, very necessary. Post 3 months, the patient must be evaluated and taken up for surgery. Patient may present with anemia. A preoperative transfusion is a must if the hemoglobin level is less than 8 gram per deciliter. And peroperatively, if the hemoglobin is less than 8 gram per deciliter, we must keep blood to replenish during surgery. Respiratory system. Patient can have chronic obstructive pulmonary disease. A preoperative X-ray will show it. A significant COPD who need major surgery should be referred to a respiratory physician for optimization. The arterial blood gas analysis should be done to check the status of the acidosis of the patient and the respiratory condition. Patient can have asthma and will require inhalers or intravenous therapy to control the asthma. Patient can have a lung infection which should be treated with antibiotic prior to surgery. In the gastrointestinal system, there can be GERD, the regurgitation risk. So the patient should be kept without food solid food for at least 6 hours and liquid at least 2 hours prior to surgery. H2 blockers or proton pump inhibitors must be given prior to surgery so that the stomach is emptied. Patient can have jaundice. If the jaundice is due to surgery, like an obstructive jaundice, then we will have to take up the patient for surgery. But if the patient has a hepatocellular jaundice, the operation should be postponed until this jaundice subsides and the liver function becomes normal. Prophylactic antibiotic can be required in infection of the GI system also. in the genitourinary system, there can be renal impairment. If there is a pre-renal impairment, this is usually due to hypovolemia. Correct the hypovolemia. Renal, the kidney is diseased. Correct the renal disease, and post-renal, due to some obstruction of passing the urine, the obstruction should be removed. The patient may have infection also here, so antibiotics are used to treat. Diabetes mellitus. Check the HbA1c level. Preoperative risk reduction strategies include lipid lowering agents and control of diabetes. In minor surgery, non-insulin dependent diabetic omit morning dose of drug on the day of surgery, and from the next day you start the same dose of drug. In an insulin dependent patient, the patient may require intravenous insulin through a syringe pump. But in most cases, if the duration of surgery is smaller in an insulin dependent patient, then subcutaneous insulin can also suffice. Patient can present with coagulation disorders like thrombophilia. Identify the risks for thrombosis. The risks are more age group, patient is obese or morbidly obese, there can be a trauma which needs surgery, the patient may be immobile for more than 3 days, like in a fracture of the leg, or patient can have other things which have made the patient immobile. Drugs like estrogen and hormone replacement therapy, and a family history of thrombosis. What are the prophylaxis? There is something called a G-suit, which is a tight legging which is put on the leg, both the legs, so that the deep vein thrombosis, which usually clots in the cuff muscles, they will not be dislodged and go and hit the pulmonary artery, causing cardiac problems. Thrombolytic drugs may be used. The HRT should be stopped 6 weeks prior to surgery. And any other disorders of coagulation should be addressed as it is required. Adrenocortical suppression occurs in patients who are on steroids regularly. There are a lot of patients who need regular dose of steroids, like patients who have asthma, patients who have less secretion of steroid. They need an extra dose of steroids prior to and during and post-operatively, so as to keep the steroid level high and avoid an Addisonian crisis. Some other disorders which we encounter are neurologic disorders. Patient has had stroke or neurological deficit. We must, in these cases, patients are on antiplatelet drugs like clopidogrel and aspirin. Clopidogrel should be stopped 10 days prior to surgery. Aspirin, ? Can be stopped for 7 days, but in case of emergency, we do not stop the aspirin and carry on with the operation. But clopidogrel has to be stopped. Psychiatric cases, they cannot be given any other local anesthetic, but have to undergo an operation through general anesthesia. Certain medications they receive, like monoamino oxidase inhibitor or tricyclic antidepressants, these should be preferably stopped prior to surgery. Neuropathies and myopathies. There are a lot of neuropathies and myopathies. You must have read them in medicine and surgery. They will require a prolonged ventilation postoperatively. And inflammatory arthropathies should be identified because postoperatively, if the patient lies down more, the chances of deep vein thrombosis and cardiac problem increases. So let's come to a mnemonic, taking a comprehensive consent. Lead in, introduce yourself and identify the patient. I am your anesthetist, I will be with you. Explore, how much does the patient know about the subject of anesthesia and surgery? Diagnosis, why the operation is being proposed. Treatment, explain whether the treatment proposed is in accordance with the protocol which runs in the hospital. Options, discuss all the options including that of doing nothing. The patient has some problem, but we say that we are not going to treat this because we will carry this over post-operatively also. Results, explain to the patient the likely outcome. There can be post-operative pain, reduced mobility. Talk about the patient's work, the patient's diet, and how long will it take to return to normal activity. Eventualities. For example, the need to remove the testicle in a hernia operation should be told to the patient that for your betterment, the testicles are being removed. Adverse events like myocardial infarction, stroke, and embolus, bleeding and specific damage should be taken into account. Check the patient if the patient is of sound mind and has understood what you are saying. Open question, check if further clarification is required. And notes, must document everything that has transpired between the anesthetist and the patient. So the acronym is led to reason. If you remember the led to reason, you can remember all what should be done with the patient. Risk assessment and consent. All life and limb-threatening complications, like life-threatening complications can be there because the patient has cardiac problem or lung problem, or limb-threatening like the patient can have an amputation, should be told to the patient that the complications of this incidence is 1%. That is, it is less than if the patient goes out into the road and meets with an accident, the chances of anesthesia causing problem is less than that. Risks related to comorbidities, anesthesia and surgery should be explained. Explain advantages, side effects and prognosis of the anesthesia. Use very simple language for communicating with the patient with simple comparisons, and a valid consent is necessary except in life-saving circumstances. And again, very important is clerking, that is documentation. A written summary of the pre-anesthetic assessment, orders or arrangements should be explicitly and legibly documented in the patient's anesthetic record. I hope I have been able to tell you most of the things. If there are any queries, again I am telling you, you write to the right authority and they will send it to me and I will explain it.